Hi everyone, I'm Dr. Yang from Joint Shantou International Eye Center. Today's topic is Anterior Ischemic Optic Neuropathy, AION. First, we need to know what is ischemic optic neuropathy. Ischemic neuropathy is caused by acute circulatory disturbance of the nutrient vessels of the optic nerves. From the picture, we can see that the central retinal artery enters the optic nerve at 9 to 11 millimeters behind the eyeball, dividing the nerve into anterior and posterior segments. Therefore, we have anterior ischemic optic neuropathy, AION, and posterior ischemic optic neuropathy. Today, we'll focus on AION. This condition mostly occurs in the elderly. In China, the age of onset is 10 years younger than that in foreign countries. The average age of our patients is around 50. AION is due to the lack of blood supply to the optic disc, caused by the posterior ciliary artery circulation disorder, resulting in acute ischemia, hypoxia, and edema of the optic disc. Pathologically, it can be divided into arteritis and non-arteritis. In arteritis, the arterial wall is infiltrated with giant cells, lymphocytes, plasma cells, and large monocytes. The elastic layer disappears, and the middle layer may have granulation tissue hyperplasia and tissue necrosis, causing thrombus formation. In non-arteritis, we mainly find necrosis of optic nerve fibers located in front of the laminar cribrosa, which may be accompanied by a small amount of inflammatory cells or erythrocytes. In the early stage, the necrotic nerve fibers contain acidic mucopolysaccharides, and in the late stage, optic nerve fibers disappear while glial fibers proliferate. Now, let's go through the etiology of AION. Hypertension, arteriosclerosis, and cardiovascular diseases are common causes. The narrowing and clogging of blood vessels caused by atherosclerosis of the posterior ciliary anterior portion of the optic disc eventually leads to AION. Other risk factors are diabetes, acute blood pressure drops such as major bleeding, shock. And internal carotid artery stenosis also has a certain effect on nerve blood supply. What are the clinical manifestations of AION? In AION, both eyes are often involved, though the interval between onsets vary, which can be weeks, months, or years. Patients usually suffer from sudden visual loss, often when they wake up in the morning because of the low perfusion pressure of the short ciliary artery at that time. Severe cases can cause blindness, especially those caused by temporal arteritis. In the early stage, we can find mild optic disc edema. The color is light red or gray-white, mostly limited to a certain region of the optic disc, and may be accompanied by small bleeding. Visual field defects are often connected to physiological blind spots because the ischemic damage of the optic nerve fibers starts from the optic disc, and the defect accounts for about 1 quadrant or half of the visual field. Investigations of AION include visual field examination, fluorescent fundus angiography, FFA, visual evoked potential, VEP, besides color Doppler ultrasound and ESR could also be helpful. The relative afferent pupillary defect, RAPD, is positive on the affected eye. In visual field tests, inferior field loss is more common and usually shows a characteristic R-shaped defect connected to the physiological blind spot. In FFA, There is regional hypofluorescence of the optic disc in the early stage, or delayed field defect. Fluorescent linkage in the lesion area can be seen in the late stage. An atrophic optic nerve would show low fluorescence. VEP reveals delayed and amplitude reduction. Using color Doppler to measure the internal carotid artery blood flow, we find that the severity of AION correlates with the internal carotid artery stenosis. In addition, high ESR suggests arteritis as a possible cause. This table shows the main differentiating features of AION and optic neuritis. The average onset age of AION is usually more than 50 years old, and that of optic neuritis is 33 years old. Patients with AION present with sudden painless visual loss, while patients with optic neuritis complain of impaired vision for hours to days, and with pain on eye movement. Visual field examination shows inferior altitudinal defect in AION, but we find central scotoma in optic neuritis. In FFA, there is delayed disc filling in AION, but not in optic neuritis. Let's finish with the treatment for AION. For non-arteritis AION, the focus of treatment is on underlying cardiovascular disease or other risk factors that help trigger and aggravate NAION. This can help control the condition and prevent additional loss of vision. Studies of several surgical and medical therapies have not shown any improvement in outcome for NAION compared to observation alone. For arteritis AION, management of AION is in effect the same as management of giant cell arteritis. In short, this means quick and accurate diagnosis followed by immediate emergency level corticosteroid therapy. High doses of steroids are given for 2 to 3 weeks, then taper back over time. But a lifelong low-dose regimen is usually needed to prevent blindness. In all cases, the results of ESR and CRP tests, as well as patient symptoms, should be relied on to guide the levels of steroid given. These are my references. Thank you for listening. See you next time.